waiting, I'd like to introduce our next speaker, Professor Jasmin Tiro, and who just joined us from moving from Texas to Chicago. Dr. Tiro is trained in behavioral sciences and public health. She's a professor at University of Chicago and associate director of the Cancer Prevention and Population Science for the UC Medicine Comprehensive Cancer Center. She has designed and tested theory-based interventions to improve HPV vaccination and cancer screening in a variety of settings, including Parkland Health, the safety net system for Dallas County, and Kaiser Permanente in Washington. Dr. Tiro uses mixed methods to identify ways providers can effectively communicate with vaccine-hesitant parents and designed an app to support parental decision-making. She currently leads the Cervical Screening Research Center of the National Cancer Institute's PROSPER Consortium, and she's committed toward disseminating behavioral interventions aimed at ending cancer disparities. Just wait a bit, Jasmin. So welcome, Jasmin, to Chicago and to our symposium.
I am going to stand off to the side so that I can occasionally see the slides. Let me know if you can't hear me, and thank you, Albert, for the kind introductions. It's exciting. I grew up in Chicago, so it's exciting to be home, and it was really exciting to be invited to present here because I'm in a period of reflection in the move and transition from Texas to Chicago, in thinking about what we should be studying from a public health communication given the recent crisis. And so this was very well timed, and I appreciate the invite. And okay. So, I really like to think about the past, the present, and the future. And, thinking about what happened with the development of the printing press and the Gutenberg Bible, in the way in which it really increased the literacy of the public, as well as opportunities to share information and to help people become more healthy, right? So knowledge is a good thing. Information is a great thing, and everything moved towards the period of scientific enlightenment from a historical perspective. If you think about the present, right, we developed the internet, right? One of the greatest scientific discoveries and investments we've made in the past century. Knowledge, is it still a good thing? More information is better, or is it a problem, right? And what we see is our public starting to think that they can be experts on everything. And what is the problem with this idea that everyone can be experts? And what is happening to the public when they need to make healthier choices, when they have this plethora of information available to them? And instead of being able to make informed decisions, we're seeing a lot of decision paralysis. And I'll present you some of my research showing that with HPV vaccination. But as I'm going through this talk, what I want you to think about is what do we want our future to be, okay? And what do we want our ecosystem from a public health communication to be, and who do we need to involve at the table to make sure that this decision paralysis doesn't hinder people's ability to make healthier choices, right? What investments in public health communication do we need to make? What infrastructure do we need to build is really something that I think all of us can participate in. And in particular, how can health scientists like those at University of Chicago work in conjunction with our policymakers to create this, conduct studies that make this ecosystem possible? So, I work in HPV vaccine hesitancy, and one of the questions is why? In 2019, even before the pandemic, the WHO recognized that vaccine hesitancy of all vaccines was the greatest health threat. And while we can joke about this, and health scientists often joke about this because it's so painful, the way in which people are responding to vaccines, and you see examples of a cartoon where we kind of meme the different types of people who are vaccine hesitant. we actually recognize that there's a very diverse mental models that drive vaccine hesitancy. We have the fears of autism. We have those that want a natural immunity, who want to eat organically and be exposed to diseases naturally. And what does that mean versus vaccines? But what it really helps us understand is that there's this huge continuum of vaccine hesitancy. It's not that small group of less than 5% that deny all vaccines, but a heterogeneous group and a largely growing group of people who delay some vaccines or just refuse certain types of vaccines because of things that they've heard. And so what we've understood internationally is that there's actually three ways to think about what's driving a vaccine hesitancy. First, at the individual level, this issue of complacency or apathy, the fact that we don't see a lot of infectious diseases and experience that, like polio and measles, in our daily lives, although that's kind of changing now that the vaccine uptake is decreasing in certain places. For example, the Walt Disney outbreak in California. And so we had this kind of low perceived risk of vaccine preventable diseases, and that you don't really need it, right? So you're complacent. We also recognize that there is the importance of investing in structures, right, to deliver vaccines, that we need to make them affordable and physically available. And we saw the huge investment with the COVID vaccine in creating these mega centers for vaccine delivery. And then all of a sudden, we pull all the funds away, and we don't have any of those mega structures now that we need to implement the boosters, right? Why did we have that kind of two-step focus? But in essence, we can't have people capitalize on make healthier choices if we don't make those choices easy to make. And that's the importance of convenience. And then finally, and tying in with statements that Albert and Marcia said earlier about this whole issue of confidence. Where is our confidence in our public health government and in the process by which we make important research discoveries that can benefit our health, right? We see incredible problems with the trust in our vaccines, trust in the system that develops and delivers them, trust in those who communicate about these new discoveries. And all of that means is that we have a lack of confidence in our system. And what that means when we as scientists and we as policymakers stand up and say do X, Y, and Z, and whether who follows through on that and not. And so, one way to think about this, and in particular, I want to talk about the context in which patients and providers are trying to make healthy choices, because what we want to have is that a provider is prepared to make a strong recommendation about vaccines, and they're prepared to elicit and address those concerns during a discussion, and that the parent is ready to think about it, is ready to make an informed decision, and then follow through with their intentions and their motivation, and get the vaccine for, in particular, their child, and then have those improved health outcomes. To study this issue of what's happening in the context of parents and providers, we looked at what's happening with vaccine hesitant parents, and we did audio recordings. And this slide is just showing that it's really hard, right, to find, and the numbers and what we need to get to find people who are unvaccinated using the electronic record, recruit those who are undecided about vaccines, get them to actually consent to audio record that visit, get providers to consent, and then actually analyze that information and deal with fun technical difficulties, like, for example, a recorder malfunctioning and losing a whole visit, which was just heartbreaking, right? But what we found when we analyzed those audio recordings is that parents tend to express their vaccine hesitancy in three ways. One way is that, and we used Rich Street's communication coding schema to categorize them. And what we see universally is that there are some parents who just express questions, right? They just are trying to take in more information, and they use the opportunity with their doctor to ask those questions. Some of them have clear feelings. There's emotions tied to this health decision, and they're scared, and they're not really potentially ready to think about their child as becoming sexually active. And so they're hesitant for that reason. And then there is about a third of them that are really quite assertive about the fact that they don't want to do it, and they're very forthcoming about saying that to their providers, and that not right now. But then the question is, what happens? What does a provider do in the context, in the face of that expression of questions, concerns, or assertion? And here's an example of an exchange that happened between a mother and a parent. And I love this because she says, I want to do a little bit more research on this, right? And I want to highlight for you the fact that she wants to do research outside of the data that she could be collecting from her provider. She wants to collect data from someone else, from some other source. And the doctor says and acknowledges it's up to you. He acquiesces and he supports the parent's decision. And then the parent says, and then, once I make a decision, I can bring them back. And she does the expression of concern that she's scared. And the provider then uses that opening, right, to persist and says, was there something that you had heard about the vaccine that made you nervous? And that open-ended question helped her explain that she was really worried about the newness of the vaccine. And then they started to go into the whole elements of the vaccine is not that new, how it was developed and how it was safe, and really reassured the mother so that in the end, the visit ended with the mother deciding to get the vaccine, that she did not need to go and do research with some other source, and that she could feel confident in that decision. And what we see when we studied our various audio recordings, and in the shaded bars are the ones that actually vaccinated during that visit, and the clear the white bars are those that did not, right? So even when the parent expressed an assertive response, which happened 33% of the time, or a third of the time, they ended up still deciding to get the vaccine during that visit. So an assertive response does not mean that you just walk away and not vaccinate. There still is opportunity to engage and discuss. And in particular, when providers used that persistent communication style, right? You saw 94% of those parents going on to decide, right? So what that tells us is that a provider's communication behavior matters. Don't waste that opportunity. Use that time to engage. And so the things to think about, and coming from Texas, I can do this in a safe space. We have to think about the context in which parents and providers are having these discussions. And I highlight for you this effort, this very challenging effort that I was faced with in Texas with a group called Texans for Vaccine Choice. And in light of the recent Roe v. Wade ruling, it's really interesting how the anti-vaxxers appropriated this choice language and used it for this whole issue of anti-vax. If you read through the elements that they say in their little ad, it sounds like something you would endorse, right? And then you see later on that they're really anti-science, right? And so you've got to be fascinated by the facility with which they engage our public to help do what all parents are trying to do, which is try to make healthy choices for their child. But it's really hard to do that with the plethora of information out there. So thinking about the national and the local context that our parents or providers are engaging in, and what are our responsibilities of our public health to support and help mitigate that context. Switching over to some of the work that we were thinking about in terms of the COVID vaccine, what we really want to do, and what we understand from diffusion of innovation theory, right, is we want a really steep curve. We want everyone to take up the vaccine the minute that it's offered, right? And this is some data a year ago, which showed that a third of the population took it, and that and had a first dose. 66% were at that time what was considered fully vaccinated. It had 2 doses, right? We fast forward, and that should say October 19, 2022, typo. We are still at 89%, right? So there still remains about 10% of the national population that hasn't had their first COVID vaccine dose. 75% had 2 doses, and 50% have had their first booster. And you can look at the CDC to look at that. What this shows you is work from my colleague, Amy Hughes, a geospatial scientist, looking at over time at the adoption of the vaccine and where it's happening in the state of Texas. And what you see at the end is, and it's going to repeat, is that lots of vaccination in urban places and less vaccination in rural places. And that's something that we saw nationally, and really Harold will probably talk a lot about this in terms of what's happening from a political polarization aspect, from a message, because you see very distinct issues among our rural population who have already gotten vaccinated, and some of the challenges, what we talked about in terms of convenience. It wasn't as convenient for rural populations to get vaccinated, but also the fact that a lot of them are waiting and seeing, even though they've had that opportunity. And you can see in blue, it's the wait and see. And then the two greens are only if they were required or mandated to do it, or they definitely would not do it no matter what, right? You see the differences in the numbers across urban and rural. And when you see kind of the reasons for vaccine hesitancy, you see that there's, issues again, like what I showed you for HPV vaccine, concerns about being too new, side effects, trust coming up again, with 38% saying a major reason why they won't do it is because they don't trust the government. And then again, like we talked about earlier, complacency, thinking that they don't need the vaccine, 38% saying they didn't need it. And when you delve into this whole issue of trust, you see what's happening in terms of who they trust, right? So while I might have a Fauci fan club t-shirt, that is my nightshirt, he's only 57% of the public trust in Dr. Fauci as a spokesperson. And the varying rates as you go down for the challenges for our public and governmental officials. And so what we see, and I talked about at this beginning, is huge conflict between the internet and vaccines, arguably two of the most important scientific discoveries in the 20th century. And so that we are, as Albert mentioned, entering into this public health communication crisis. And what you see here are just some statistics illustrating this crisis, right? 36% of frequent social media users held at least one false belief about the COVID-19 vaccine. 58%, or almost 2/3 of the public, are overwhelmed by the information. 57% say that the government is not giving them the full picture of the pandemic. What does this context mean for us? But the fact of the matter is that we actually had a lot of tools, and I just want to talk a lot about what tools we could be doing to intervene on this vaccine hesitancy. And there's a lot of science that shows us how we can do a better job reaching and informing the public, and that we really need to be moving beyond fact-based informational materials, because more information is not necessarily better. We can think about how we can apply behavioral sciences, economics, neurosciences, issues about how we understand people make decisions, to think through being more effective in our communications. And that we need to think through deploying our communications in a stepped up sequence. And an example of that in particular is, what do you do earlier on, right? And what we saw in the COVID pandemic is our former presidents getting the vaccine, right? The importance of influencer appeal and norming the behavior of adopting the vaccine, using trusted messengers. And what you see here in the center box is one of the largest African-American churches in Dallas had a virtual forum interviewing those individuals, particularly Kismekia Corbett, who is an African-American who was part of the NIH team developing the vaccine, and the importance of having those forums to share that information. The idea of nudge, right? And here at UChicago, you guys are all very familiar of nudge, right? So what this one study done by Katie Milkman at UPenn worked with Walgreens and did nudges via text messaging, right? And what she saw is that just by sending a text with the simple message of a flu vaccine has been reserved for you, got 11% bump in the number of people who went undoing, right? It's not you should get a vaccine. It's reserved for you. The framing of the message matters. But other types of questions, and what you see here is how many got vaccinated as a result of it. Dedicate your flu shot to a loved one had a little bit of an effect, right? So the social element of protecting your loved ones, but not as much of that whole you're special, it's reserved for you. The other things is that we've seen through work by the UK, similar nudges about simple messages, responding to emotions and social. Your loved ones need you, get vaccinated. Now we have the chance to return to the people and the places we love. We can come back and be social and communal. If you get the vaccine, let's get our lives back again. We also saw over the course of the pandemic, the fact that you need to update information to be more relevant, right? So with the advent of the Delta variant, right, new opportunities to reach out and say, this Delta variant is evolving, it causes 2 times as many infections. And various folks like Project Unity in Dallas worked together to get that message about the increasing risk of the Delta variant to stimulate those who had waited and try and get them to get vaccinated. Thinking again about the sequence of stepped interventions, we can get a little bit from the influencer appeals. We can get a little bit from nudging, but then we have to really think about what we do in that next step. And that's where my work in self-persuasion is really important, because what happens to people when you mandate a vaccine versus you support their vaccine decision making, particularly in this day and age where resistance and fears of conspiracy or government overreach is so high, right? So I'm in favor of supporting that deliberation process and helping them engage in that as opposed to just passively receive that. And we see that in both elements of engagement through self-persuasion and motivational interviewing. And that's what my app developed. So my app is an educational website. It supports decision making and avoids decision paralysis. They watch a video that gives them basic information. The video takes about 4 minutes. They then choose among a range of different topics to kind of brainstorm on, where they then verbalize their answers and they summarize their answers that helps them make a decision today. If they have remaining concerns, we connect them to a provider to have those concerns addressed. But if they decide to get the vaccine, we help them make that plan and connect them to resources. And we've shown that this, app is and website is accessible to all. It's accessible in particular to different literacy levels because the patients are verbalizing, as opposed to originally the original test was in writing it because it was done with college students, right? So what can you do when you verbalize those answers? And they can verbalize them in both English and Spanish, so we can reach our Spanish speaking populations. Our randomized controlled trial showed that 32% of individuals who were exposed to the app decided to get the vaccine just after watching the 4-minute video. Another 34% decided to get the app after verbalizing reasons. But if you do the math, that means 1/3 of them still did not decide after being exposed to this app. And in understanding the mechanisms, we realized that what the verbalization did is, instead of just passive reading materials, it was active engagement in that material. And as a result, they had better memory for the reasons why they were choosing for the vaccine. That was the mechanism of how it was working in helping their motivation and their follow through of the plan. But you're probably wondering what happened to that other third. And here is an example of where our exit interviews or qualitative interviews helped us understand. One parent said, the iPad said, and I like this, the fact that she said the iPad said, okay? The vaccine doesn't say, let's say it didn't say those words, the vaccine doesn't sterilize my son, but I said, why are they saying that? So it made me think, is there a possibility that a vaccine could cause that in people? So by us trying to actively rebut a perspective shared by others, we actually potentially induced it in some who might not have been exposed. Very challenging thing, right? So issues of rebutting myths can be harmful, okay, which we've seen. The other thing that they said is whether they trust the app. What they said about the side effects, what they said was too short. They said it was the same as measles or fever or sensation of fainting. So if that's the case, if what they're saying is true, then I would say it solved my problems. Yes, that's what they say, like what the experts are saying, then I don't have a problem. But you can see this distancing, right? They don't know whether they should actually fully trust the app, me, the developer of the app. And so the question is, who should that app be distributed by? Do I need an intermediary to say, a community health worker like Marcia was showing that vets that app and then hands it out to the community and says, I use this app. I like this app. I like what it helps you do. Would there not be that distance of they? Okay, what don't we know, right? Because I'm a scientist, there's still things to be done. Albert did a really great job highlighting public health communication, and I have a very similar definition. I add the word inform, right? I also think it's really important to highlight that definition uses the word empower, right? I think inform, those verbs of inform, influence, and empower are really important for us to think about. But think about what those goals might be. One goal might be providing complete and accurate information to the public about public health issues. Another goal might be influencing the public's behavior to prevent societal harm, right? What if those goals conflict? What do public health officials decide when those goals are in conflict? And that's a study that I'm doing right now with Dr. Emma Levine, interviewing public health officials as well as social media influencers to think through the choices that they make in selecting their messages and how much information to share and the ways to frame it. Because you could think about it just to illustrate. These are both true statements during the COVID pandemic. We do not yet know whether the vaccines will prevent you from spreading the virus to other people, even if you yourself do not get sick. That is a true statement. Think about how that statement would be received by various folks. Alternatively, vaccine was tested in clinical trials. It is safe, it is effective, it protects against severe disease, hospitalization, and death. We expect the vaccines will greatly decrease the spread of the virus and are still collecting data to figure out how much. We always monitor approved vaccines. What are you signaling with that other type of message, right? What are you trying to highlight about what we know, but also highlight and help people understand there's sometimes things we don't know, but we have to make decisions and we have to make recommendations in that context. So we have a fragmented healthcare system. We also have fragmented communication channels. How do we reach people with no medical home? Our community health workers, one important strategy. How do we reach people who are in information silos and echo chambers, right? Who are, as Albert illustrated in that first slide, hanging out with their red group, hanging out with their blue group, and are utterly convinced of certain beliefs or only hearing certain pieces of messages. We can't ignore the structural factors that are important in accessing information, particularly as we saw with the COVID vaccine. Most of the initial offers were done through internet, right? Those that do not have internet cannot take advantage, and it's not convenient for them. And so we need to think through investing both in broadband access to the public, because that is an important social determinant of health. And we also need to think about digital literacy. Just because you have internet does not mean you do good things on the internet, okay? Digital literacy is a very complex construct of skills that we're trying to build in our adults and our youth. And that's why I was really excited to see last year that Illinois was the first state. It's kind of sad that they're the first state and that more people didn't realize it sooner. The first state to have high schools teach news literacy. How do we teach our youth to be better consumers of information on the internet. I don't think we totally know how to do that yet. We need to counter the info epidemic. And one of the things that I think is a challenge, and this is the last thing to think about, is how do we do, because information and the spread of information can be very viral, how do we do real-time debunking of misinformation? How do we prepare our local environments to do that? What do we need? And that's why I'm really interested in working with various folks about how we invest in and build what we call a resilient ecosystem, right? We need to network. We need to partner with our community leaders, with our policymakers, to refine our intervention messages in a very short period of time so that we can be responsive. We can't wait for people to show up in our clinics. We cannot wait for people to get their internet access. We must use our expertise to reach out, and we need to think about all of the different levels and stakeholders who can be participating together in this to educate our public, because the next public health crisis and emergency is imminent. And are we doing the science and are we doing the investments that we need to so that this happens? I just want to end because it's really important that you hear from the community and link back to this concept of trust. One of our community leaders in our community advisory board at Simmons said, the most important operative word being trustworthy. The average person is bombarded with pandemic information from questionable sources. God forbid something like this happens again. I hope the government entities will be better organized, not appearing to fight each other, causing citizens to choose sides. I hope that too. And on that, I'll stop and take questions later. And email me if you need anything.
Okay. Is Carol here? Oh, we have a 15-minute break. Thank you for the reminder. And we'll be back at, is it 10:40? It'll be 10:45. Okay. Thank you, everybody. Great talk so far. So we'll be back at 10:45. I'm so happy to see you. Oh yeah. Oh no. I come from a family like that, so. Today is our okay, so I gave you. We have 15 minutes. It's pretty much. Yes, we will. We'll once it's up, we'll make sure. Okay. Sorry. So after this,
we'll select the national guidance font. And then obviously our audience page, she will have slides to put up the logo. And then there's a Q&A. We're just going to put it on the